Hi, I'm Jack Cush with Room Now. I'm here with our best friend, Kevin Winthrop. Hey, Kev, how are you?
Good, Jack. How are you? Nice to see your face.
Yeah, it's still COVID. Kevin, as everyone knows, is a professor of medicine, ophthalmology, public health, I think carburetors and everything else at Oregon Health and Science University in Portland, Oregon. Uh, Kevin, you've been tremendously helpful to the rheumatology community in this year, giving us a lot of good instruction. As you know, there's a bit of a flurry of interest and questions with the release of the new Pfizer COVID-19 vaccine. I want to review a few things, ask you a few questions. So first, you and I, along with Jeff Curtis, Artie Kavanaugh, a few other really smart people, were on an interesting work group that developed slides about vaccination in rheumatic disease. Can you give us a few basic takeaways on how well vaccination goes in patients with rheumatic disease first?
Yeah, the literature is pretty decent. There's a dozen plus studies that have really focused primarily on the usual vaccines, that you see in everyday practice: influenza, the two pneumococcal vaccines. More recently, the PCV13. Really, just the last couple of years, you see some studies there. Most of the literature there is on Pneumovax, the old polysaccharide vaccine that we still use. And then, there's some stragglers there, studies with tetanus. Many of the studies have been meant to answer, two questions. One, how well do the vaccines work from an immunogenicity standpoint in a disease state versus, healthy controls? And then the other types are kind of within a disease state, RA, for example, examining the effect of the DMARD on not efficacy, but immunogenicity. And so to summarize those in 2 minutes or less, I mean, obviously there's a lot of review papers out there. You and I have helped with some of them, but for the most part, autoimmune disease patients in general, obviously some are sicker than others, but they don't react to vaccines as well as a healthy control that's similarly aged and sexed. And then depending on the DMARD, those immune responses might be more diminished. So what DMARDs do we worry about? Obviously rituximab, B-cell depletion therapy in MS or RA or wherever. I mean, that is a major concern with vaccines. And it's very clear the farther you vaccinate out from rituximab, the better. So, I try to get people their vaccines, the ones we're talking about, 6 months after the last rituximab or later. And sometimes it's a bargain with the rheumatologist to say, hey, can they go a little bit longer before you give them the rituximab? And then waiting 2 weeks after you vaccinate them, right? I mean, it's that 2-week post-vaccine period is critical in terms of immune response building. And then there's some data around methotrexate, of course, with influenza. Holding it at the time of vaccine administration for 2 weeks can improve influenza responses. There's a lot of data with methotrexate pneumococcal vaccine, not experimental data in terms of like hold it for 2 weeks and see what happens, but just comparing groups of people on methotrexate to similar groups of people who are not on methotrexate. You certainly see methotrexate dumbs down a variety of vaccine responses, particularly pneumococcal vaccine, and that's been well studied. And outside of that, most of the studies show that there's some effect by JAK inhibitors, there's some effect by TNF blockers, but usually it's in the quantitative outputs. So maybe the immunogenicity is a little bit lower, but the proportions of patients that are reaching satisfactory response or immunoprotective levels seems to be maintained. So those drugs probably do have some effect, but not as much as the others I mentioned.
Yeah, the remarkable thing about that exercise and the data that we reviewed was of all the new therapies and whatnot out there, it was surprisingly good how much of an immune response you could actually get even being on those new therapies. And while there were studies which showed some diminished responses, overall, the only thing that really stood out was that rituximab data and the methotrexate effect. So, and I think this is telltale for our patients who are now considering a new vaccine and patients who are on therapy. And those are the two drugs that we need to be concerned about. We'll talk about maybe specific recommendations for those at the very end. The package insert on this, or if there is a package insert with the EUA, emergency use authorization, it does say those who are immunosuppressed may have a diminished immune response, but they didn't really study that. They certainly did not have patients in these studies who were included because they were immunosuppressed. So our patients are largely a virgin population, yet the two drugs, the Moderna vaccine being approved today, the Pfizer vaccine on the market right now, both those studies being done in 30 and 40,000 patient populations or subject populations, with all ages, with comorbidities on board. Is there any solace in those big numbers, even though there are no immunosuppressed patients in there?
Yeah, I mean, I think a couple things. That's safety data from the vaccine studies so far. Those two programs that have really presented their data looks great. I mean, there's really small numbers of usually self-limited events. I mean, there's a little imbalance of Bell's palsy. I think 4 cases in the Pfizer program versus 0 in the placebo, and kind of something similar in the Moderna program. There's a few cases of appendicitis, but there's nothing in those data sets that, even if they are related to the vaccine, that would preclude you from wanting to get it right now. I mean, the risk benefit is clearly on the benefit side. In terms of autoimmune disease, obviously, could those vaccines cause autoimmune disease? That's an open question. The follow-up isn't really probably long enough to answer that question. But I doubt it. And in terms of people with existing autoimmune disease, of course, you're right. The patients on immunosuppressive agents were excluded from those studies. But I think what you're suggesting is probably right. I suspect there were people with, mild autoimmune disease in those studies that just aren't on biologics, for example, or on DMARDs. There had to be a few of them, people with mild psoriasis that just weren't on immunosuppressive. So, we don't know that the vaccines can flare autoimmune disease, but I will tell you that mRNA vaccines in general, as you know, they elicit a very strong type 1 interferon response.
Right.
It would not surprise me if they could cause a lupus flare or even an RA flare or something else. So I think that's something obviously we're going to address in future studies. But again, those flares can generally be handled too. So probably, again, even if that is a risk, the benefit of the vaccine outweighs it.
Yeah, I think that's a great observation, and one that should be considered. On the other hand, 70,000 patients treated. If the mRNA were eliciting a type 1 interferon response in these people, that would give rise to some of those side effects that you notice usually with vaccines. You would have thought that maybe it would have given you more autoimmune features or more autoimmune type flares, and that really has not in the profile of what we've seen so far. So I think that's encouraging. And again,
Yeah.
the really rare things that you talk about, single digit reports, versus 70,000 as a denominator. Again, everyone has to make a value judgment about whether or not there's a risk here for any individual patient. What do you think? What do you make of the generalized comment, like patients who have allergies should talk to their doctor before they get this vaccine?
Well, I hope that's not true, because that means everybody's going to talk to me and you and everyone else, because everyone's got allergies. Right. Clearly the 2 cases of anaphylactoid type reactions in England generated that initial press release from the British Regulatory Authority. And it really was centered on people who've had a history of anaphylaxis before, and not just allergies. So, whether that's important or not, I don't know. It seems reasonable if you had, someone asked me too, like, well, what if you had Guillain-Barré syndrome before from a vaccine? I highly doubt this vaccine is going to give you what, something else gave you, or a natural infection gave you 10 years ago. But so the anaphylaxis thing, I think that's the issue. It's not really allergies. It'd really be a prior anaphylaxis episode. And even that, I don't, it's 2 cases in England, kind of like you're talking about. We're talking about 4 cases of Bell's palsy in 20,000 people, or a couple cases of anaphylaxis in thousands and thousands of people. So I think that you should talk to your doctor about if you have anaphylaxis type problems. But to me, I would solve that by getting the vaccine and having an EpiPen right next to right next to me in the clinic, and be in a place that you could get help if you needed it. I wanted to answer though your first question, because I transitioned to the second part of that question. But the first question was, in the package insert, which I think you're right, there's probably not even packages yet or inserts, but the idea that people who are immunosuppressed may not respond as well. And I think, it's probably true. And we certainly see that in the vaccine literature with the other vaccines we talked about. I also think you can extrapolate a little bit from natural infection. We do see that people who are immunosuppressed who get COVID tend not to mount as much of a robust immune response, at least in terms of antibody titers. And they are more likely to shed viable virus for longer time periods. So, I do think there's something from that we can draw from that probably if you're vaccinated too, you probably won't have quite a robust response. But, obviously that would vary upon what disease you have and your disease activity, and then probably what DMARD you're taking.
So as we're going to wrap up, I want to give you the discussions I've had with my docs at UT Southwestern. First, someone's on rituximab. Should I just wait until they get the vaccine to get their rituximab, even if I have to hold the rituximab infusion another month or 2 or 3? Is that what you would recommend?
Yeah, I think we're in that kind of 3-month zone of probably having more widespread vaccine, where most of our patients are going to have access to it. So I think it's probably time to start holding it. Yeah, if you think they can do it. Obviously it depends on their disease activity, but
yeah. Next, the tough one about methotrexate and whether you should hold it for 2 weeks like we do with influenza. But let's remember the timing here. You get the initial vaccine, then you got to get your second shot 3 weeks later. So then you're going to have to be off of it, another 2 weeks? So is that you're off for 3 weeks or 5 weeks? And, you can be off methotrexate for 2 weeks without a flare. I would argue you should just continue methotrexate and hope that second shot gives you that big amnestic response. Talk about how much protection you get with the first shot and then the second shot 3 weeks later.
Yeah. You've seen the data presented at the AdComs, there's not a whole lot going on immunologically on day 21 in terms of antibody titers or cell-mediated immunity. Clearly, so these are 2-shot vaccines. Day 21 or day 28 is the booster, depending on which vaccine it is. So you're right, it does complicate that idea of holding the methotrexate. When you look at the week or 2 after that booster shot, that's when you see pretty high titers and really maximal vaccine response in those programs. So I don't know. Would it be better to hold the methotrexate for 2 weeks around the primary, or around the booster, or around both? Those are really open questions, and it's really complicated to do that clinically. So I think if I was tempted to do anything, I might hold it for 2 weeks around the primary shot, and then I'd probably restart it. If they're super stable and you think they can go without it longer, then I think you could do that, but just depends on flare risk and all those things. I will say that steroids, from all those other vaccines, steroids do not really have much effect on vaccination at all. And I'm talking low dose steroids.
Right.
So, we're talking 5 and under, maybe 7.5 and under. So, if you get into a flare territory where you use in high doses, that could be really detrimental to a vaccine response, I think. So those are the 2 factors you've got to play with as a rheumatologist. Yeah.
Yeah. I think that I kind of agree with you. If I was going to hold methotrexate, and I'm probably not, to be honest with you, if I was, I would hold it during the first part, because I'd want to get as many memory cells as I could, doing the hard work to get ready for their next takeoff, which they're going to get in 3 weeks or 4 weeks with the second shot. I think that that when you look at those graphs, there's a pretty steep curve on titers and reactivity that if there's a blunting by methotrexate, it's not going to be enough, I think, to really hurt the patient. So
I agree, and it may not make a difference at all. If you look back at that influenza work that I was involved in with Dr. Park and Dr. Bong Lee, when we went back and looked at that, and Xavier Mariette was really key in that, looking at why that effect was there, it really had to do with the initial levels of BAFF in the individual. And the people that had really high BAFF levels, we saw a difference whether we held their methotrexate or not. But the people who didn't, it really didn't matter.
Right.
So I don't know, who's who in terms of their BAFF level, and certain diseases or certain individuals obviously may have higher or lower BAFF levels. So I don't know. I'm with you. I'm not sure it's something that you need to do. I'm not sure it would make a difference. If I was going to do anything, I would probably either not do it or just do it the first 2 weeks, because I really don't want people to flare and end up on higher dose steroids. And the other thing too is I tell people, you know what, you're going to get some decent protection out of these vaccines. And if it's not good enough or it doesn't last that long, which it might not, this may last 6 months or 12 months. We don't know how long it lasts. And I suspect it won't last that very long. I think we're all probably going to be getting different kinds of vaccines and in the coming years to protect us from this. So, the protein-based vaccines are coming. And there's the adenoviral vaccines, which, I don't know how they're going to play out, but we'll have, probably 5 or 6 players in the marketplace by the summer.
So in the rollout of the vaccines, 21 million healthcare workers are supposed to get it first, then the 3 million nursing home elderly are supposed to get it. And it seems like there's a good plan at my university, your university, who's going to get it, what stage, what group you're in. I was lucky enough to get mine. I know you're waiting on yours, and that's going to happen. But our patients are asking, Doc, should I get it? We're saying yes. When can I get it? How am I going to get it? Do you have any insight as to how those people in group 3 and group 4, people who are either elderly, people who have autoimmune disease, whether they're immunosuppressed or not, are they likely to get it at their doctor's office, at a central location, or at a Walgreens or CVS? What do you think?
Yeah, it's a big question. There's a lot of efforts planning both at the state level, and obviously we have a new administration at the federal level. So that's going to be different. I mean, there's a lot of planning going on, I know, by the new administration, pre-planning, I guess you'd call it. Right now we have a very decentralized system, and it's being left to the states. And I suspect it'll become more of a uniform approach probably with the Biden administration. But I don't know. I think a lot of it's going to be dictated by the type of vaccine and who can give it, right? And if you need a negative 70°C freezer, you're going to have a vaccine only at certain places. You're not going to have it at Walgreens. So the Moderna vaccine that doesn't have as much freezing requirements, and then the AZ, some of these other vaccines coming, they're going to be easier to give in a community-based setting rather than an institution or academic institution or research center. So I think a lot of that, the state health departments, obviously, no matter what administration's involved, are going to be key on trying to steer vaccines to places that can handle it and manage it and keep it viable. And then, of course, give it. I suspect that's why I think, people are pretty optimistic, like, oh, I'm going to get vaccinated next month. And I keep telling my patients that, maybe, but probably not. It's probably going to be a couple months. I mean, I tell my patients, I just saw 20 patients today. I told every one of them, I mean, I'm thinking March, if you're lucky, it'll be pretty widespread, and that you can call me up and I can say, yeah, come on in. We have a special clinic and we're going to run people through the clinic to vaccinate them.
Yeah, and that's a number. That's the same date I've been giving my patients. I tell them, I'll support you. I'll help you get it. When I know more, you'll know more. It's probably going to be on the news. That's where we'll both find out about it. But we need to wait and see at this point. Could you close with some comments about the ACR task force that you're involved with regard to this vaccination and our patients?
Yeah, sure. There's there's a guideline effort, so for vaccinations in general. So that has just been started. So ACR has decided it's time to renew our vaccine guidelines, and so I'm part of that core group. And so we're in the process of starting a systematic literature review, et cetera. Everything we do we're making our PICO questions, Jack. I hate PICO questions.
I know.
Yeah. Anyway, we're going to do that. That's what we're doing first. But and in that context, we also have a special task force that we have assembled and tasked with a very rapid disbursement of expert opinion based advice, using probably a Delphi method and guessing, and based on kind of the things you and I were just talking about. What do we see in the rest of the vaccine literature? What do we know? And what do we know about the immunology of these diseases and the drugs that people use? And so there will be some guidance, I think, given pretty soon, probably in the next few weeks or early January. That guidance will be kind of like the therapeutic task force that I was involved in. It's expert opinion at the start, and 6 months later, there'll actually be some data. So, it'll be a living document, and we have plans to study some of these questions. So Jeff Curtis and I have a large Shingrix study that's hopefully starting soon here that we're going to layer on some, hopefully some COVID vaccine recipients and see if we can understand the immunology. And we're hoping to do that with ACR and a variety of people like yourself and others. So stay tuned on that.
So the good news is that you guys are on this and working on this and are likely to deliver something before our patients are going to actually need to know some real details. So the timing is just perfect, and we really are blessed that that you and Jeff and others are so on top of this and working hard at this. So Kev, thanks again for your time. I'm sure we'll be talking again soon.
Yeah, I'm glad you got vaccinated. Good for you. And let me know how the next one goes. It looks like you feel fine, right? You're 24 hours out. You feel great.
Really had no symptoms at all. I'd have to say on my arm, I have to show you the Band-Aid, but maybe 1 out of 10 pain, and that's an exaggeration. So I'm blessed. My partner who was in the study, she had Catherine had a lot of symptoms and whatnot. I've had nothing. So
yeah. Well, the last thing I'll say, and then we'll turn the cameras off and you can take your shirt off. We'll look at your Band-Aid. But older people, if you look at the data, and probably immunosuppressed people, probably people with autoimmune disease, they're probably going to actually do better with the vaccine. Less reactogenicity, less local or systemic side effects, and probably fly through it a lot easier than a 25-year-old or a 30-year-old. So that's
right. I think in her case it was youth and beauty that's working against her, and that's been my windfall. So all right.
It's finally paying off to be old, Jack, right?
All right.
Hey, great to catch up with you.
Thanks, everyone.
Yeah, cheers.